Phase 3, no benefit of this lymphadenectomy. And what is the role of adjuvant therapy? And when you treat invisible cells, you randomize. What are the risk factors? This is very important. You know all these risk factors: lymphovascular space invasion, the age, grading, the myometrium, the stage, and you divide it in low, intermediate, medium, or high risk. But when you look in the literature, they tell you that in fact this is not at all reproducible, because all these parameters are somewhere subjective, and if you don't have the central revision of everything, you are not sure that you put in the same category the same patient. One thing is sure: if I was the Minister of Health of Egypt, I will fight against obesity, because obesity in oncology with tobacco and alcohol is the main factor of cancer. And this is what happened in United States in 1990, 1999, and the present time. When it is red or brown, it means that your index max body is above 25, and you increase your risk of having endometrial carcinoma. And look at what happened in less than 10 years. And I know that the Egyptian food is very good, but be careful. External beam radiotherapy, endometrial. There is a lot of randomized trial that you heard yesterday. You reduce local recurrence, you don't change nothing to survival, and every time you do external beam radiotherapy, you increase the toxicity. And in endometrial carcinoma, this will be my message. Don't look at survival. You will not change it too much, maybe with chemo. Local recurrence is important, but most of all, especially in obese patients, look at the toxicity. So vaginal brachytherapy. There is 3 trials. The one in low risk by a Swedish person in 2009, surgery alone versus vaginal brachytherapy. Surgery alone, vaginal. Recurrence significantly reduced with the vaginal brachytherapy. But you see, with surgery alone, the rate is quite low. No difference in pelvic recurrence. Overall survival, no difference. Maybe 3%, grade 1, 2. So the question is, what is the balance? Should you do nothing, or should you do vaginal brachytherapy? If you do vaginal brachytherapy, you have a small gain, but you should not have any toxicity. Now let's go to high intermediate risk. The PROTECT trial, the Lancet, it is external beam versus brachytherapy alone, 21 grade. External beam, brachytherapy. Vaginal recurrence, no difference. Pelvic, a bit more when you irradiate on the vagina. This is quite understandable. Overall survival, no difference. Toxicity, and this is important, when you do external beam, 54%, only 13%. The last one, already in medium risk, vaginal breast. It is again Swedish trial. External beam plus brachytherapy. Brachytherapy alone, external and brachy. Nearly no difference in vaginal recurrence. Pelvic, slightly more, of course, when you do no external beam radiotherapy. No difference in overall survival. And here again, when you do external beam radiotherapy, significantly more grade 3 toxicity. And the conclusion of these 3 trials, which is written in their conclusion, in the high and intermediate and medium trial, both of these trials, they conclude that vaginal brachytherapy should be the adjuvant treatment of choice. And here again, vaginal alone should be the treatment of choice. So it is clear that in this high, intermediate or medium risk factor, vaginal vaginal ball brachytherapy is the good treatment. And in the low risk, you have the choice on brachytherapy or nothing. Small benefit. If there is no toxicity, you can hesitate between both treatments. So when used alone, this vaginal brachytherapy, you to have no toxicity, you reduce vaginal recurrence, in low-risk cancer, maybe surveillance or this. In high intermediate, vaginal breast therapy, you have some recurrence, but it's not so frequent. And in practice, most of the institutions will use vaginal brachytherapy after endometrial surgery. What is the technique? It used to be radium or cesium with manual afterloading or with remote loading, and now in most of the institutions it is iridium. You can do low dose rate with manual afterloading, you can do pulse dose rate with remote loading, and more now it is high dose rate. You use iridium, and there is a trend to use cobalt, and this is the inverse square law. You will be surprised if you do the dosimetric analysis that with the cobalt, which has an energy of 1.2 MeV, you have exactly the same distribution around the sources with iridium, which is 0.3 MeV. Because at this proximity of the source, the inverse square law is much more important than the energy, and close to the source, the energy is playing no role. The only bad thing with the high energy is that with cobalt, you need a huge bunker to do the brachytherapy, and that iridium, the bunker is smaller. You need a vaginal applicator, and this is what is in most of the institutions. It is a cylindric vaginal applicator, and you load it with pulse dose rate, manual loading, or more and more high dose rate brachytherapy. What is the dose? Most of the time the dose is prescribed at 5 millimeters below the applicator surface. In France, we give 6.5 by 4 in 1 week. In the States, 7 gray. Who is right? I don't know. There's a trial where there's 6 gray, 4 fraction, 4 weeks. I think this kind of dose is quite standard dose. And be careful, because in Sweden they made a randomized trial some years ago where they compare 15 gray versus 30 gray. And with 30 gray, they have a severe vaginal atrophy. So the limit of tolerance is not very far. Some personal experience. I made a special applicator that I published for this vaginal irradiation, and the idea was, when you look at the scar after hysterectomy, it is not a cylinder, it is a straight line, and the vault of the vagina is not a cylinder. You can make it a cylinder, but the normal anatomy after surgery is not a cylinder. It's why I imagine to have 2 sources of iridium, and I asked the computer to design the isodose in the frontal view, and to make the same thing on the lateral view. And then I asked the engineer to design an applicator who have exactly this shape. So I knew exactly what was the dose at the surface of the applicator. And the applicator was that size because it was much more adapted to the horizontal scar of the vaginal vault after hysterectomy. And I knew that the dose was here at the surface, and I knew the dose at 5 millimeters and at 2 centimeters. So this was the applicator that was introduced in the vagina and close to the scar, and it was fixed to the patient with this ribbon and fixed to the waist of the patient. And the surface applicator conformed an homogeneous isodose. So the remote after loading, 7 gray surface in 3 to 8 minutes is iridium, 14 gray in 2 fraction, 1 week apart. After external beam radiotherapy, we treated 4 centimeters, the width was 3, the thickness was 6. And when you give here 7 gray, you give here at 5 millimeters, 0.3 gray, and I like to know the dose to the surface of the mucosa. For me, it is a good way to be sure not to overdose this region. This is some result. We have treated 106 high-risk patients, combining external beam and brachytherapy, vaginal recurrence, pelvic area, overall survival, toxicity. Is there an alternative to iridium? I think that in the future, with the accent and the small source that I show you, and with the intrabeam and maybe with the papillon, we will have an alternative to the iridium or to the cobalt. This is what I showed you a few minutes ago. It produced an isotropic 50 kV beam, This is the vaginal source. You have a different set. This is the machine. This is, you plug it in the machine and you move the source, this source at the end, and you introduce it here, and you do exactly like with the iridium source. And this is 50 kV. The problem is that this source is very fragile and the price is very expensive. But maybe in 5-10 years they will succeed to replace iridium sources or copper sources with a 50 small courses, and it will be a revolution in brachytherapy. What is so an evolution is the intrabeam. You take the intrabeam, this is the generator, the electrons, you produce the isotropic 50 kV source, and you put it on the stepping mechanical device. And you have here the vaginal applicator, and you step the source in the vaginal applicator, and you have here a phantom which shows you that you give an homogeneous dose to the vaginal vault with 50 kV and not anymore with iridium. And here again, the inverse square law is much more important than the energy, and with this machine 50 kV, you have no problem of fetal protection. But sometimes you have recurrence. And if you have recurrence, how would you irradiate them? And this is again some quite old experience that I get. It was treatment with interstitial brachytherapy of the vaginal vault. And this was also the idea. This was the applicator. It was the Paris system, the basal dose, and the 85% of the basal dose. And I hired the engineer to design an applicator which was exactly following the isodose of the 85% basal dose. When I give 20 gray, I knew that it was 20 gray at the surface of the vagina. And of course it was 20 gray around the needles. So that was the applicator. You start by implanting one needle in the vagina, another needle in the vagina, then you position the applicator and you introduce the 6 needles. It is very easy, it is always parallel, and you have a perfect geometry. And you have this, and this is the patient. You implant here, another one here, and you put the placator, and this is the results. And I could publish out of 78 patients with vaginal recurrence after cervical endometrium, 70% local control, 10% grade 3, all these grade 3 in previously irradiated pelvis. And this is the following of this story. Now you can do laparoscopic guided, because they are always afraid when you do this implant that you put a needle in the small bowel. So you ask the surgeon to do laparoscopy when you implant the needle in the vagina. And this is what you can achieve, and this is done in Aarhus in Denmark. And yesterday we heard that when you do some surgery and you look at the paraortic nodes, you can find nodes in the paraortic region. But to irradiate the paraortic region and the pelvis region in obese patient more than 65 years is quite toxic. And listening at this talk, I thought I could show you what happened when you have a paraortic recurrence. It is not really brachytherapy, but not far. It is intraoperative radiotherapy. It started long ago. It was revised by the Japanese, and we made a lot of them in Europe. I made more than 700, and I treat some recurrence and some uterine recurrence. You do IORT, you operate, you look at the tumor, you remove, and you control. And this is, in 1994, a recurrence in the paraortic region of an endometrial cancer, a big recurrence. This patient was treated with external beam and IORT, and she is still living now more than 15 years after that. So even when you have a paraortic recurrence, you can cure a patient. So elective irradiation of the paraortic, you must think of it. Conclusion. Brachytherapy, in 10% of all the radiotherapy patients, is playing a major role. This is an example, but it is true for head and neck, for breast, for anal canal carcinoma. It is in permanent evolution. It is a highly accurate and conformal targeting irradiation under control of the vision. There is no problem of accuracy. It is image guided also. High dose in small volume, high therapeutic ratio, but of course, as it was said, you need training, you need clinical practice, and with that you will prevent local recurrence with no survival, you will avoid late toxicity, You make it fast and simple, good technique, HDR, I think, is the future, and maybe some cases of interstitial brachytherapy, and maybe in the future 50 kb. I thank you.
Thank you, Dr. Jad. I think because of shortage of time, we can postpone question to the end of the session. And now we can move to next presentation by Dr. Suhair.
Next speech will be on cyberknife overview of innovation.